We had 4 entries for this, and he was and his paper was selected because the committee found it to be one of the best ones. I'll just read out few things about him. He has been the former Dean of Punjabi University, Patiala, and a member of the Medical Council of India. He was the president of IOAF in 1994. He was the president of Indian Foot and Ankle Society 2002-2004. He has 125 research publications, and out of them, many are international. He was a recipient of B.C. Roy National Award in 1994. He was given a B.B. Joshi oration by Indian Foot and Ankle Society in 2010. And now he has been, he received the B.N. Sinha Meritorious Award also yesterday. He has many other prestigious awards, and he has many innovations to his credit, which include a low-cost scoliometer, a low-cost Elizaro, and a low-cost mechanical hand. We welcome you, sir, and we are looking forward to your talks.
Dr. Maria, Dr. Sudhir, and my dear colleagues, I am extremely grateful to the Indian Orthopedic Association for inviting me for this prestigious oration of the Well, sir, this is a zero research project, and I dug it out and zeroed on to the dollar and dollars in the form of gratitude of hundreds of my patients. I start with this Vedic prayer: O Lord, lead me from falsehood to truth, darkness to light, and death to immortality. Swami Vivekananda said, take up an idea, think of it, dream of it, until it is realized. It's golden jubilee of this, my tryst with the clubfoot, and I still hold on to it. Probably I'll continue it, and maybe till the platinum jubilee. From a humble start of a well-documented 100 cases for silver jubilee oration, my experience has enlarged to 1,000 cases in obstinate deformities during the last about 25 to 30 years. A complete metamorphosis of this concept has taken place during this time, and numerous innovative ideas for a total correction have been evolved. There have been many landmarks. A generic name of obstinate has been given to this deformity, a crisp name of dollar given to this surgical technique, and a terse name of dollars adding Z plasty to the dollar has been evolved. A terse name of SSR given to the subtotal subpillar release, and evolution of an entirely evidence-based step-by-step correction has been evolved. A very important fact: a new version of this highly intricate 3D pathoanatomy, tibialis posterior being considered as the single most important factor, new thinking on equinus, predictability of triple orthodesis, and symptomatic genu recurvatum, many more new things. Every case gave an opportunity to think, and new ideas emerged every time to correct it. There have been numerous reports in the literature, but none has been entirely satisfactory due to incomplete understanding of the pathoanatomy. This term covers every possible rigid clubfoot. A severe rigid, it is defined as a severe rigid deformity at any age, not amenable to conservative treatment or other surgical techniques. It is classified into two major and two smaller groups. There are numerous factors responsible for obstinacy: complex pathoanatomy and adaptive changes. These, we have no control over these, but the others can still be controlled. Early surgery in infancy is no good because there are large number of recurrences. It's very important to remember that each clubfoot is different as regards amount and rigidity of deformity. And the evidence is very clear even in the newborns. Different anatomical factors, different age-related adaptive changes, unusual other congenital defects will be described later. They reflect their own changes. For correction, a judicious pre-op assessment, planning and meticulous selective use of various surgical steps is imperative, often additional ingenuity required at the operation table. Now, although founded on a detailed study of pathoanatomy in 15 deformed feet of stillborn compared with as many normals, yet newer interpretations have made surgery more evidence-based for a wider application. This is the classification of pathoanatomy studied in the specimens. Most humbly, I pay my homage to the feet of those 15 little angels who did not see even the light of the day, yet they immortalized themselves from the long forgotten divine existence in the closed museum jars by getting the 3D pathoanatomy and its interpretation unfolded for evidence-based step-by-step total correction. This technique has been used by me since about 40 years, and during the last 25 to 30 years, more than 50% were older children, adolescents, and majority were revisions. A good clinical examination and X-rays are imperative in each case. I don't operate before the walking age. Follow-up period varied from 6 months to 30 years, and in 600 feet it was more than 5 years. Briefly, various soft tissue releases in this extensive release are posterior, medial, subtotal, subtalar, lateral and stellar releases besides calcaneo-cuboid wedge resection, tarsometatarsal mobilization and talonavicular reduction selectively, of course. This is not a quick fix operation, but has some extra learning curve involving a judicious use of large number of surgical steps. To achieve the best results, there are two natural questions: cause of this common problem and the best treatment. A step-by-step evidence-based answer will be provided. Now, starting from the skin contracture, it's a three-dimensional contracture. It's very important and it is proportional to age. The evidence is very clear on passive manipulation. When you manipulate the foot, dorsal side becomes wrinkled and loose. On medial side, it becomes tense. Comparison of the surface area on the dorsolateral aspect and postomedial aspects. A simulated two-circle diagram as drawn on the right side on this specimen is a proof which in one plane only, but as it is a 3D contracture and hence a 3D incision has to be evolved. Age-related and scar-related evidences are clear. A unique contracture will be described later. Therefore, it is mandatory to correct this contracture. Now, for this 3D contracture, an unusual 3D incision, that is dollar, a long curved hockey-shaped incision from dorsolateral to medial side, prolonged on the leg as shown. In most severe cases, dollar plus Z incision will be, Z plasties added to this incision will be required. To avoid necrosis of flap, it is very important that a thick limited flap of 1.1 to 1.5 centimeter only is designed. For closure, it is imperative to place the first stitch at the right place. After estimating the rotation of flap towards postomedial side as demonstrated, dollar plus Z will be required, giving additional length of the medial side. VY plasty for a unique myofasciocutaneous contracture will be shown later. Now, these are the individual muscles, abnormal above and normal below. The difference is very clear. Abductor hallucis, now the muscles. Abductor hallucis is a small muscle, but it is hypertrophied and contracted, and it does contribute to varus. Needs sliding forwards. Gastrosoleus is evidence-based. The evidence is very clear in this. And you can see this is, the short, the muscle belly extending down as compared to the normal, and the evidence is clear in this specimen also. For correction, cutting the medial half from the calcaneum while doing Z-plasty is important. Tibialis posterior, muscle belly is hypertrophied, extends more distal. As you can see in this specimen, the most important single factor, and everything else can be explained on this basis. Age enhances the deformity. Evidence is provided by the 9 strong insertions pull the bones towards medial malleolus in 3 dimensions, whilst all soft tissues and bones follow. It can very well be compared to 9 tentacles of nonopus, which is an octopus variant, taking its skill towards the mouth, and also to the closed fist of the human hand, where all fingers are directed to the middle of the thenar eminence. Similarly, the tibialis posterior pulls all the bones, and the bones become crossed up towards the medial malleolus. For correction, therefore, it is imperative to dissect and divide all insertions to open up the intertarsal and tarsometatarsal spaces selectively, of course. Plantar aponeurosis, flexure digitorum and long flexors, evidence is very clear in this specimen. For correction, Stanley's procedure, division of both long flexors at the knot of Henry. Conjoint posterior capsule of ankle and subtalar joint is a very important part of pathology. It's a thick, short, continuous sheet of 3 ligaments as given over here. It's a major cause of incomplete correction, occult equinus as well as manifest equinus. 6-fold evidence is there, as you can see in this photograph. And the evidences are rocker bottom foot occurring while applying cilious prosthesis, break occurring at the weak point in external fixator treatment, genu recurvatum with clubfoot, reduced tuber joint angle in the lateral diagram, incomplete tendo-achilles lengthening, resulting in occult equinus, which becomes evident on sitting on feet for ADL in India, and manifest equinus, which is even evident while the patient is standing, as is in this case. Even after complete division of the tendo-achilles lengthening, the heel doesn't come down. So these are the 6-fold evidences for correction. Therefore, not only the tendo-achilles, complete division of conjoint posterior capsule from lateral to medial side, opening both ankle and subtalar joints under vision is very important. This case was operated, tendo-achilles lengthening was done probably somewhere at the age of 1 year. This deformity persisted because conjoint posterior capsule was not treated. Spring ligament, another important part of the pathology. In normal foot, it's a thick, wide triangular structure between sustentaculum tali and navicular, supporting the talar head and forming a significant part of talocalcaneo-navicular joint. Under surface of the talus has 3 articular surfaces, 2 on the calcaneum and 1 on the 3 on the, instead of 3 normal surfaces, spring ligament area is missing. You can see this is shown these 3 areas, and this is the spring ligament triangular, and in this deformed foot there are only 2 areas. This spring ligament area is missing. Talonavicular subluxation of this location. To explain it further, all the earlier surgical steps make the talus adequately free from calcaneum, but not completely, to allow requisite amount of correction. This is the concept of subtotal subtalar release, that is SSR, which is more than the partial release, which leads to inadequate correction, but it is less than complete, which leads to overcorrection. This is the middle path for optimum correction. A bonus of this subtotal subtalar release, besides restoring the space for spring ligament and increasing the medial length, it also closes the dorsolateral wedge from the as done in the modified Evans procedure. Now, this dorsolateral hem on the is very important in the calcaneocuvert area. It increases with age. Only soft tissue correction is ineffective in children above 4 years and even younger in very severe cases. Evidence is clear in dissections, scargram, and even intraoperative. Modified Evans procedure, that is excision of dorsolateral edge from cuboid, and not the calcaneocubar joint as is done in original Evans, facilitates varus correction and also retains the calcaneocubar joint. Other adaptive changes, equinus deformity is not simple as it appears. It's a complex deformity comprising 4 components, besides of course the occult and the manifest equinus which I have already mentioned. Firstly, at the ankle joint, which is it is usually thought of. However, on deeper analysis, there are 3 more elements are there. Secondly, heel equinus, decreased talocalcaneal angle in the lateral X-ray due to talonavicular dislocation and conjoint posterior capsule. Thirdly, forefoot hindfoot equinus. As you can see, there is a 90-degree deformity at the forefoot hindfoot. Any one, 2 or all 3 may predominate in the varying degree, complicated by other elements of inversion and adduction. Fourthly, an oversized talus vis-a-vis ankle mortis in sphere equinus of more than 20 to 25 years duration. Now, evidence, there is a 6-fold evidence already given in the describing the conjoint posterior capsule, correction and predictability of triple arthrodesis. Colleagues, it's very important that only rigid and sphere, all components of deformity more than 20 to 25 years in an adult, if recurrent, will need triple arthrodesis only. All others can be corrected without triple arthrodesis. It's my firm conviction from this research that triple arthrodesis can be avoided in majority of adolescents and adults by a judicious approach, and I'll show you in the cases. Now, symptomatic genu recurvatum. It's a common observation that club-footed children walk commonly with hyperextended knees, even rotational alignment, without any symptoms. But I have seen 2 symptomatic cases which I will be describing. I'll now show some of the illustrative, very rarest of the rare cases, of course, you see, which I am going to demonstrate. Without triple arthrodesis and then with triple arthrodesis, symptomatic genu recurvatum, additional congenital defect, and dollar plus Z illustration. Now, this case, 13 years, corrected without triple arthrodesis, recurrent, you can see the scar of the previous surgery and a very severe, you see, deformity corrected with this technique without triple arthrodesis. This 22 years female, again corrected without triple arthrodesis. Earlier, I had the impression that probably it is very difficult to predict whether triple arthrodesis will be required or not, but now you can predict it. This is 17 years operated in Indonesia without triple arthrodesis. This is 17 years, again no triple arthrodesis was done, and you can see the deformity well corrected and even occult equinus, patient sitting comfortably on the feet. 35 years male, this patient you see was not bothered about the deformity, but he had bilateral fractures, both bones of both legs, and you can see the interlocking nails, and this deformity increased with this after these fractures, so he had to be this necessitated surgery, and this was treated, you see, with this technique with triple arthrodesis, and you can see, you see dollar plus Z scar on this corrected foot and the patient having wonderful correction. Again, this is a unique case, rarest of the rare. The whole of the foot was only one bone. All the bone was fused together, extensive tarsal collision, inferior tibio-pupil fusion, and extrastosis, with a, you see, dense adherent scar on the medial side. First stage was only this dollar technique, partial correction, and then second stage, this is, you see, was done intertarsal fusion because you couldn't, you see, say it is triple arthrodesis, again dollar plus Z. This 18 years male, you see this patient had, you can see bilateral genu recurvatum with, you see, posterior subluxation of tibia, again treated without triple arthrodesis, foot was corrected and not that the knee deformity has got automatically corrected. Now this patient, again with genu recurvatum, and this deformity persisted for 11 years. The patient was not bothered until it, you see, the knee deformity appeared and the gait was awkward, and the patient wanted corrected. They came for the knee deformity, not for the foot. The evidence is clear in this X-ray. You can see the scar of the previous operation, And as I told you, this is the, you see, cutting of the conjoint posterior capsule. You can see the talus jutting out between the subtalar and the ankle joint. That is what I mean by division of this conjoint capsule and undervision, cutting this joint completely, cutting this ligament completely. And you can see the patient sitting on feet. X-ray will show the posterior side opening up after you divide the conjoint posterior capsule. Now this is a unique case. I have not seen such a case before. I don't know whether any of you have seen. This patient had absent metatarsal, flail toes, forefoot flexed plantarwards 180 degrees due to additional plantar myofascial cutaneous contracture. Now this was treated by a indigenous, you see, this soft tissue distractor which I just designed myself, got it made from a local workshop. It's a very low cost, light fixator and multi-part soft tissue distraction mechanism inbuilt. VY plasty of the plantar soft tissue was done in this case, and you can see the correction achieved in this case. Osteoglycosis, one side corrected very beautifully, the other side had recurrence at forefoot, hindfoot. A dorsolateral wedge resection at revision surgery corrected this deformity. Now this 7-year-old female, extensive adherent scar after 2 surgeries, treated by this technique, and you can see even the patient sitting on feet and the footprints appear normal. Now this is a illustration which I wanted to show, operated only 6 weeks back. Extensive scar all over, you can see, the scar on the posterior side, on the medial side, you see this is a bowstring keloid, and on the plantar side, and even a ring, constriction ring at the ankle. And this was treated by this, you see, excision of the scars, and there are 2 Z plasties, you see this one and this one, there are 2 Zs. And you can see at 6 weeks, this is the correction and the child sitting on feet. Wonderful correction with such an extensive scar. This patient was operated only 2 weeks back. You can see the deformity. This is 22 years male, bilateral foot. I operated the more deformed foot, and on analysis I could predict that this foot will be corrected without triple orthodesis. And this is the, you can see the talonavicular, this is the navicular, this is the talus. Complete dislocation of the talonavicular joint, and this is the incision. These are 2 Z, you see, this is 1 and this is 2, incorporated in this dollar incision. And as I was telling, 9 insertion of the tibialis posterior. Very important, all the 9 insertions have been dug out from the sole of the foot, and you can count all 9 insertions in this, you see. You can see, all the 9 insertions have been dug out, and this is the correction, and you can see Z plasties, wound beautifully closed, and the heel has come down equinus, hind foot equinus has been corrected, only forefoot equinus is persisting. This will be corrected by a dorsolateral wedge resection without triple orthodesis in this patient of 10 to 2 years. And conclusion, take home message in this, all these have been already told, but some of them they do need, emphasis. Equinus is a complex deformity. Correction of occult equinus is imperative for activities of daily living in India. Need for triple orthodesis can be predicted with proper, examination and analysis of the deformity. Genuine curvatum can be symptomatic and a presenting feature. Treat foot and not the knee. Long-term follow-up without any adverse effect proves its solid concept. Each club foot is different. Very important to remember. No 2 feet can be similar, and they need individual attention. First, a very selective use of knife and meticulous use of knife. Lastly, 25 years back, I got Silver Jubilee Award for this work, and now the Golden Jubilee Award itself is an evidence of acceptability of this technique, evidence-based technique. While in Agra, you have to think of the Taj Mahal. Everybody exclaimed its beauty, but only a few think how difficult it was to build it. Started in 1631, 22,000 workers, 1,000 elephants, and for 22 long years. An old age saying, practice makes a man perfect, but man can never become perfect because practice never ends if you want to improve. My grateful thanks to all of you for your kind attention, and may God bless you.
Thank you, sir. For a moment, we'd like to present you the award.
Next is a Silver Jubilee oration. Again, we had 4 entries, and this oration, as you know, is given to people who are less than 50 years of age. For that, Dr. Rajiv Rao was selected, and we invite Dr. Rajiv Rao to give his oration. Dr. Rajiv Rao is working as a, please come over the station. Yes. He is working as a professor and head of the department at Jubilee Medical Mission Hospital in Trishur. He graduated from Bikaner and did his MS from Jodhpur. After doing some work for some years in Rajasthan, he ultimately shifted to Kerala. He has been in the past also recipient of various inland fellowships of IOA, particularly Deputy Johnson one. He has been given awards during APOA, WOC, and AOS meetings also. We welcome you, Dr. Rajiv Rao.
Slides on. Good morning, respected chair, teachers, colleagues, dear friends, ladies and gentlemen. I'm thankful to IOA for giving me this opportunity to deliver the Silver Jubilee oration on a simplified axis which is around the ankle, the complex ankle which has been discussed from the morning itself by Dr. Taneja, Dr. Mittal. I'm just going to say about what is my study to introduce the same. I bring greetings from Kerala, where I work. This is the capital city of God's own country, Trishur, and the hospital where I work. I dedicate this talk to my teachers, from where I learned my basic orthopedics 24 years ago, where they taught me orthopedics and made me to walk. And I just work on their principle of learning and trying to say about the simple axis of this complex ankle, which includes the tibio-talar and the talocalcaneal. Let me take you to a common example or a common condition which all of us over the time come and see and deal with. There is a fracture which has been at the level of the ankle. The talus comes out and it disrupts the ankle joint, and it also disrupts the subtalar joint where the calcaneum is lost its contact. We all go around by doing a simple solution, putting up a pin which gives us the maximum anatomical alignment of the calcaneum to the talus into the long axis of the tibia. Taking to another example where there is an open ankle fracture, subtalar joint has been disrupted, there is a fracture of the medial malleolus, the talus comes out of the situation and leading to a neurovascular structure damage. This was being stabilized by after debridement by a Steinman pin, which gives the maximum fixation with the minimal implant which has been used. This particular stabilization will help to let the plastic surgeon go across. Coming to another spoke wool injury around the ankle where there is fracture ankle with dislocation and subtalar as well as ankle dislocation. It's a simple problem commonly seen by all of us, and this was been ending up into some situation. I'm sure all of you would agree that it needs an ankle fusion, because being an open, it was being just stabilized by a simple Steinman pin going across the calcaneum, the heel pad, into the long axis of the tibia. By seeing this, this is a simple example, simple method which has been doing it, but basic thing stands up. How do we align the tibia, the talus, and the calcaneum in one line? I'm sure all of you would like to avoid a situation like this, where the pin is trying to be addressed from the calcaneum into the talus, but it is misdirected. It has directed extra-articularly, or it has taken a different axial line in the same. I'm sure if you know the exact line to put this pin into place to let this common problem be targeted just like a bullseye, what Mr. Dhyan, in football, the hockey fellow who could do it, Dhyan Singh, could do is to put in a big football, a ground, put a hockey ball into a tire, which was his intention, to targeting the same. So if you can target it perfectly, that was the reason. The biomechanical axis which we have been using over the years in THR, TKR, it stops up at the ankle and it extends to the second toe, which is what we have been using over the years. The fantastic eyeballing technique that we can pass a pin from the calcaneum into the talus, into tibia in the long axis is the ability of the surgeon over the time. But can this be reproduced by a young colleague? On this particular motto, we thought if this is to stop at this level and it extends into the frontal way, but there is no description of this axis going from the tibia into the talus, into the calcaneum in different planes, AP, lateral, posteromedial or medial views. So I intended to work on this so that we can go with more accuracy into the tibia in the long axis. With this particular interest, I started evaluating that can we find out those points, or can we describe an axis, or can we describe a line which will take up the ankle as a whole up to the foot and can align the tibia, calcaneum and the talus in one line in a plantigrade described foot. So we intended to start up our study to target that particular axis. The study was being intended to go for a proper direction aiming from the tibial long axis into the talus, into the calcaneum. So we set this as a TTC axis. We tried to make an anatomical study just before we could embark to the radiological part and combine it to the cadaveric studies. I would just like to take you that this study is intending only to be on a plantigrade foot in a neutral situation. So the anatomical study which said we try to make a long axis of the tibia which touches the posterior surface from the dome of the talus and goes all the way to the calcaneum. Where does it look from the medial aspect? We draw an imaginary vertical line. Try to go to the specific points on those that it touches the center, the long axis touches the center of the dome of the talus. It goes from the middle facet of the calcaneum. If you see the lateral view and the medial view, it passes from the angle of Giselle and it goes down to the earth in a normal plantigrade foot. We tried to make an observation that where does this axis go for? And this axis which we try to describe, try to make that can we describe this targeting from the calcaneum into the talus and into the calcaneum. This three is the complex which we often address, but the general validated science which says about tibio-talar and talocalcaneal. But to combine it all together, this goes to the long axis of the tibia, long axis goes to the dome of the talus, and from the middle facet of the calcaneum. This knowledge we thought we'll start up for the cadaveric part. For that we made certain protocol model that this would be our planning of mid-sagittal and mid-coronal study for a plantigrade ankle and a foot. With this, we tried to make all what has been in reality, taking ethical committee clearance, whatever the amputated limbs for diabetic other reasons were being taken up, 9 cadavers were being put for. We tried to mark the tibia long axis by putting up two K-wires in the mid-tibial axis in lateral as well as mid-sagittal and mid-coronal planes. After marking this, the bone was being sectioned and we wanted to see where these points look for. The mid-sagittal point or the long axis of the tibia touches the dome of the talus in the middle part. It goes through the angle of the gisand at this point at the middle facet of the calcaneum. The mid-coronal sections of the long axis of the tibia again passes through the dome of the talus. It goes through the middle facet, but just lateral to the middle facet in the calcaneum was being point marked. We thought where would be if we combine the mid-sagittal and the mid-coronal planes, and the point was at the center of the dome of the talus, and this point was just lateral to the middle facet of the calcaneum at the articular surface at subtalar joint, which was being tried to made a radiological look by going through two X-rays which are being put at right angles. This is only depicting the two X-ray machines were being put at right angles on a platform. The ankle was stabilized in a wooden board and weight-bearing X-rays were being taken, and the line which was being drawn from the long axis of the tibia up to the ankle, and it goes to the second ray as we have been doing it for the same. Then we took non-weight-bearing X-ray of 20 individuals where we could put the patient on an AP and a lateral view by taking a full length of the whole tibia and extend it into the second ray. Our observation was that there was 3 to 4 degree of dorsiflexion which happens on weight bearing should be neutralized, as we are operating on these patients in a supine or a lateral position, so weight bearing part has to be taken off. We extended this study to the modern gazettes and the CT plane, the long axis of the tibia to the second toe, and try to do this in AP views, in the lateral view, in postero-anterior view, as well as from medial-lateral views, and we saw this axis was passing what the reference point have been narrated till this. This passes through the long axis of the tibia to the dome of the talus, lateral to the middle facet in the calcaneum on the subtalar surface in mid-sagittal and mid-coronal points. With this, we thought that we can do the same part on an MRI. Probably it didn't give any extra information. The soft tissue part could be much more demarcated, and we did mid-sagittal and mid-coronal section studies. Combining with this particular idea, where were we? We had some variation of 2 to 5 degrees at the dome of the talus and 0.6 to 1.4 millimeters from the middle facet lateral to the angle of gisand. That was the point which are being marked. Could we convert this study and combine that? We took our cadavers and tried to make a point of entry and saw them on the C-arm. This variation was insignificant because the Steinman pin used was 4.5. The variation of the alignment was being neglected because the width of the implant. This particular part we thought we could do a much more targeting. Now we are very sure that if we target through this axis, we will go and reach to the bullseye. This particular thing which has been observed on C-arm, we tried to make our observation, can this be converted into a clinical practice? On the same cadavers, we tried to pass up a nail from the retrograde way, and we could anchor the nail in the same anatomical fashion what we depicted our Steinman pin could go. So this was giving us some situation where we had already embarked that we can go this by seeing an AP lateral or posterior view, whichever view. So there were being trying to make surface marking for the axis which we are designed, draw a long axis along the tibia which goes up to the second toe on a frontal view, but from the foot if you try to see, make a line from the second toe, go all the way to the bottom of the heel and divide this into 4 by 3 different transverse line at right angle. The junction between the frontal 3/4 and the posterior 1/4, if you try to hit an axis there, you will hit the target of the long axis of the tibia. This made us to go that we could embark on something. But before embarking, can this axis be of some use? I'm sure all of us, when I've been taught our postgraduate days, we talk about fracture ankles and the biomechanics. We talk about the position of the foot at the time of injury. We talk about the forces which are being acting. But our teachers have seldom told on which axis this act. Could we explain our ankle fractures on this basis? And I'm sure if you look into the vertical compression, the pylon type fractures when patient is loading on his or her ankle, probably on a fall, or when he is standing and rotating, or when the foot rotates, the body rotates, whichever way, the torque which would be combined. Can we explain that on this basis? We try to look that we could explain certain pylon fractures, the ankle fractures, all these can be explained on these principles. During postgraduate days, the Potts fracture, pylon fracture, all have been explained up in different names. But if you try to look into the anatomy, it is a fracture of the medial malleolus, lateral malleolus, posterior malleolus, the anterior or the lateral part. All these can be explained. If you try to visualize this, on this axis, the ankle rotating and breaking one after another, whether it is a different name can be given to this fracture because the inventor did it, we remember it, but I'm sure all of those can easily understand on the axis which can describe these fractures at a go. Coming to the clinical utility of this study, constraints of time, I'm not trying to put up the statistics. We use this axis for treating ankle fractures, treating arthrodesis on certain cases where we had managed CTVs, and I would like to let you go through the same. Whenever we talk about TTC axis, I'm dividing this into a distraction group where we distract the whole limb on the same plane, and whenever we distract it, we try to achieve a good anatomical reduction at the ankle with which we can go for a stable fixation, and followed by can an ankle soft tissue be well managed, and if this can be achieving, can it be done? Let me go through this particular principle, what we have been doing it over the year 1996 or to 86 or 46, whatsoever it may be. Fracture pylons were being treated in a way by putting up a calcaneal pin traction. And I'm sure today we put up an X-fix and wait for the skin wrinkling. Why this all worked up together? Why this all works? Probably the forces are acting on some axis to let it go through the same. Let me take you through the examples where you could see that a fracture ankle, pylon fracture, which has been managed with a poor skin condition on an external fixator. Elsewhere in the whole world, if it works on some axis. With this particular cases, the clinical utility of the TTC axial distraction in a comminuted fracture, which is compound, a poor skin condition, which has been distracted on an external fixator, passing a pin into the tibia, going all the way into the calcaneum, and the structures were being stabilized by minimal 2K wires, and the lateral fibular plating ends up with a good union at some point. Another case where C2 fracture with an intra-articular and a metaphyseal extension, where is a poor soft tissue, this all can be stretched on the same and let the fracture unite and wait for the distraction to be done. It heals up well. Coming to an A1 type with a gross edema where it could not be nailed up, this fragment could not be nailed, and this unnailable fragment was being put up by passing a pin from the tibia through the fracture fragment into the calcaneum, and this was being distracted and immobilized, followed by it went into for healing. Dear friends, I am sure by this axial distraction, any kind of fixation will hold if the principles of distraction or the biomechanics is being held. These are the X-rays which have been available to me and at my own, because there was no biological plates available when I started off this. But these simple implants can hold an ankle fracture to that level. Coming to the utility of this fracture, this TTC axial distraction versus axial stabilization, I'm sure all of you would do that, stabilize the ankle on its anatomical plane in a plantigrade foot. You had already seen this open fracture ankle, which has to need a stabilization where the plastic surgeon can come and give you a better ankle and a stable ankle. This is what has been done. A spoke wheel injury commonly encountered where there is an open fracture ankle, where the ankle was being stabilized by passing a pin from the calcaneum in the desired direction. Medial malleolus was stabilized, the lateral column was stabilized. This ankle has gone into for a very good healing at the end of 3 months. A spoke wheel injury where talus has come off the place, part of the talus is lost. After 86 months, the ankle has gone for a fusion, but it has been a plantigrade ankle where the person could go for work. A geriatric age problem, 87-year-old female patient who had to undergo a stabilization by passing up a pin, which has been done all the way. At this point of time, after 2 years, the nail has been removed, ankle is fairly stable of the lot. This was being done on an axial stabilization. Coming to the problem which has been commonly discussed and told is CTV from morning, we know. Probably I tried to convert this into a pediatric principle. If you could do so, we do a posteromedial soft tissue release. If you see the pins, pin has been passed from the calcaneum into the tibia, into the talus, from the long axis. It maintains for 4 weeks. Once we remove the cast and mobilize the ankle joint, the whole anatomy is restored by a bony stabilization. This only holds for a temporary. Another rigid deformity, if you see this child who has got a vertical talus presenting at the age of 7, we stabilize this talus by making it horizontal and passing a talocalcaneal pin which is going all the way into the long axis and stabilize it for a 10 weeks period and later on. So deformities of the children can also be stabilized on the principles like this. An interesting case, 3-year-old child who had an absent fibula, an absent fifth ray, had an angular deformity of the tibia, and the parents came with the same thing. I tried to apply the principle where I corrected the equinus and angulation, stabilized the calcaneum under the tibia in the long axis, and if you see, after 7 years, this child who has undergone the surgery and could walk, his foot looks near normal, he could perform all his activities. He has an absent lateral ray. The same DTC principle could be applied for a compression because it's ultimately to get a normal plantigrade foot and ankle, which would be helpful to walk for and restore the mobility of the patient. Let me go through certain examples. This pin is to be planned, which goes all the way from the calcaneum as desired. After freshening up the surfaces of the talus and of the tibia, and a Charnley's compression clamp can be applied. Here is a case where it's a recurrence of the GCT. The talus has been eroded from the superior surface into the tibia, as well as the subtalar part has been involved. It was being fused by putting up a Steinman pin through the resection of the GCT of the talus, freshening up of the tibia and the calcaneum, and it was being fused. We achieved a stable, and patient has no recurrence for last 11 years. We quite often see open fracture of talus where talus has come out, it has been infected. We stabilize this talus stabilize the ankle in a plantigrade foot and got for a fusion for this. Coming to the situations where this ankle could be going for a stable fixation, after the stable arthrodesis, the pin can be removed because it hurts to the patient. We do see certain flail ankles where patient had paraplegia, now have to walk because of lot of other modalities which can be done. They have a lot of equinus deformity. You resect out a wedge from the talus, try to realign the calcaneum and talus under surface of the, okay. Can I fix it up? So this equinus deformity at the ankle can be corrected by taking a wedge from the, I think it is on 47th slide. Yes. Good. And a resection of the wedge from the talus and foot was made plantigrade, followed by a stable fixation. Commonly discussed, a 36-year-old lady with a neglected clubfoot deformity had an ankle like this, and I'm sure what Dr. Taneja would love to do a procedure, or Dr. Mittal has already told you about that what can be done. Probably this was being stabilized on the same principle, anterior wedge was being taken up, patient had first time walked on a plantigrade foot, and she was happy to share with her this photograph and her video. In spite of asking that we would like to do it, she said she would love to be there. With the same moment of energy, the patient said that she would be happy to share for a scientific cause. I conclude my talk that this TTC axis, the tibio-talocalcaneal axis, which could be used to help for the students to early understand what is the mechanism of the fracture, what way the medial lateral malleolus and the posterior malleolus can break, the vertical compression. It can be helpful for the teachers to explain how does this all happen. And I'm sure for the clinicians, this provides us a guideline of treatment. Can this be used as a part of axial distraction if you do it on the same plane? If this can be done for compression to achieve a stable fixation, or any of those things for a busy clinicians. Yesterday, Dr. Tanna tried to show a very comminuted tibia, and he stabilized, and he said united with some amount of recurvatum. I'm sure this recurvatum can be avoided if this axis could be taken care. This particular axis can also be used for making this as a part of the result evaluation, that how is ankle in AP plane and the lateral plane and in the posteriorly if you look into it. So this could be an axis which could say the index of acceptability for any fracture reduction, and it would help us to evaluate the plane of deformity correction also. I acknowledge this work to my team, to the surgical team whom I do work along, to my parents, to my friends who have been very much to stimulate my gray horns to talk and think about this particular subject, and at the last, my wife. I thank you one and all.
Thank you, Dr. Rao. Kindly receive your award, which we have the pleasure of presenting to you on behalf of Indian Orthopedic Association.
Now is the time for Kini Memorial Oration talk, and as you know, it is given by past presidents of IOA. I invite Dr. Raj Shekharan to the stage to give this oration. All of us know about him, but still it is my duty to say few things. He is the chairman of the Department of Orthopedics and Spine Surgery, Ganga Hospital, Coimbatore, and adjunct professor of orthopedic surgery, Tamil Nadu, MGR University. He has been holding presidentship of several associations, not only IOA. He was the president of World Orthopedic Concern UK, president of Computer Assisted Orthopedic Surgery Society India, and founder chairman of trauma section of Asia Pacific Orthopedic Association. To his so many list of awards, I think the most prestigious award has been, he has been also elected as the Hunterian Professor 2011 and 12 by the Royal College of Surgeons of India. His research potential all of us understand. His main interests have been in disc nutrition and diffusion tensor imaging of the spine. We welcome you, sir, and looking forward to your lectures.
Thank you very much, sir. President of our association, Dr. Maria, Secretary, Professor Sudhir Kapoor, my most respected past presidents of this association, senior lecturers, colleagues, and my dear friends. Thank you very much for this great honor of delivering the Kinney Memorial Oration. And the subject that I have chosen today is snakes and ladders in one's professional life. In one's professional life, to deliver the Kinney Memorial Oration is a landmark, a memorable day, and it becomes doubly pleasurable if you got the chance to dedicate your oration on somebody as eminent as Professor M.G. Kinney. It is said that a life is measured by the legacy that one leaves behind, and to this, Professor Kinney stands very high. From a humble origin, he became the person who established the Department of Orthopedics in Madras Medical College, when it was the Madras Providence and covering many southern states. But it is not the administrative post, but the far vision he had, because at a time when data collection was not considered to be important, he powered the idea of data maintenance. He emphasized on clinical research, and that is why his scientific papers and lectures made him a leader in this field. Naturally, there were many awards and honors in his name which he got, and as Professor Mailvan and Natarajan wrote in his obituary, we veritably stand on people like him on the shoulders. Let us be worthy of them. Now, if you look at his life, there are many important facets that made him great. And looking at that, I thought that I should talk today about what makes a person a leader in the profession. How can one achieve professional excellence rather on some orthopedic topic at all? Now you may ask, what does snakes and ladders have to do with professional excellence? Because we all think of this as a childhood board game where you throw the dice and you finish when you come at the mark. But on the way, you can have many ladders that take you up and many snakes that can bring you down. And if you look at it, it is just not a child's game, because the origin of the game goes into ancient India, where it was actually told to the children as a method of teaching the law of karma, as a way of taking them to the ladder of salvation. Even today, in many parts of India, they are all played with different names: Moksha Padam, Vaikunda Pali, Paramapada Sopnam. It all means, how do you reach the top? How do you attain salvation? And ingrained into this is the principle that there are many ladders of virtue which can take you up, and there are many snakes of vice which can bring you down, crashing. Now, in the original game of many hundreds of years ago, these were the squares of virtue: faith, reliability, generosity, knowledge, and asceticism. And as you can see, the squares of vice are much more, probably showing that God gives you the possibility of snakes much more temptations in life than more ladders that He gives you. And it is in our ability to go around it to attain professional excellence. Salman Rushdie, in his book, Midnight Children, clearly told, this particular game has morals. The eternal truth that for every ladder that you hope to climb, there is a snake waiting just around the corner. And for every snake, there is a ladder to compensate. And I think we should remember this as professionals, because this is what is going to differentiate one over the other in the long professional life. I think when we all begin the profession, we are all like this at the start of a marathon. Everybody has high aims. Everybody has high ideals. Everybody wants to be number one. But unfortunately, there is only a few who are actually number one and who finish the marathon. Now, our association is fast growing. We are more than 10,000 members. And there are about 300 to 400 members, young people, joining every year. And majority of our members are less than 40 years. On the other hand, I am now 54 years old. I have more than 25 years of professional experience. And during this period, I have watched and learned from many people, see them go, how high they go, and maintain their position of leadership. We have also seen many people who go very fast up, but come crashing down. And there are many people who wither away even in the middle. So this is just sharing my thoughts to the younger generation in the Indian Orthopedic Association. And if it helps somebody to clarify a few thoughts in their mind, I would have been very lucky. Now, how do we play the game of snake and ladder? Now, as we start the game, it is important that you should play at number 6 or 5 even before you start. And I think this can be equated with the training that you get before you start your profession. I think the two important ladders at this stage of life which will take you up much better than others is professional competence and skill. And these are things which the young surgeon must really concentrate on